2702. I'm sorry, I wrote that down wrong. So 2702. Okay, Senator Thompson.
I have one, Mr. Chair.
Okay, before we go to yours, let's make sure nobody has any objections to mine.
Yes, I'm a little ahead of the game, aren't I? Sorry about that.
All right. Do we have any objections to introduction of RS 2702? Not seeing any. That bill is introduced. Senator Thompson.
Thank you, Mr. Chair. This is RS 2554, and this is making appropriation for the Midwest Stem Cell Therapy Center. That's doing a lot of research. They have phase 2 trials ready for work that would be helpful in the most severe COVID patients. And that's RS 2554.
Do we have any objections to the introduction of RS 2554? Not seeing any. That will be introduced as a committee bill. Do we have any other bill introductions? Okay, not seeing any. We will get right into our next order of business, which is a presentation on the state of health in Kansas. With us is Acting Secretary Janet Stanek, KDHE, and Ashley Goss, Deputy Secretary for Public Health, KDHE. Acting Secretary, welcome to the committee.
Thank you. Nice to meet all of you. Thank you, Chairman. Oh, sorry. Thank you, Chairman and committee members. Glad to be here. I've met a few of you. I'm trying to make the rounds. This is week 7 for me in the new role. I want to thank you, first of all, for this important work that you do on this committee, helping keep all Kansans safe and healthy. I wanted to just do a quick introduction of myself. Prior to joining the KDHE team, I had been at the State Employee Health Plan as the director for the last 15 months and enjoyed that work and got to know a lot of you and a lot of the important work they do there to provide benefits and wellness program and clinic to Kansans. Prior to that, I'm about a 38-year careerist in hospitals, hospital administration, last at Stormont Vale, 21 years. In the last 11 of those years as the Senior Vice President and Chief Operating Officer. So I was feeling really well positioned to take on this role and appreciate your support. Since I've been here, I'll just give a quick rundown of what I've been working on. Jumped right in and immersed myself to try to support the staff. They've been working very hard, particularly over the last 2 years, as everyone else has with the pandemic and what we faced. They also have a number of other duties, though, that they've had to balance. So I want to commend the team at KDHE and everyone for supporting all of the other functions that need to continue. I've also worked on identifying opportunities to align the different divisions within the agency. As you know, environment, Medicaid, and public health all intertwine in one way or the other. So I will continue to do that and try to connect dots and find out what we can do not only within our agency, but also with key stakeholders throughout the state. I have a pretty wide network, and I'm feeling very, very good about my colleagues throughout the state and how we might be able to work together. Ashley is going to present the public health measures today, and I guess, Chairman, I'm not sure if questions need to be asked. Should we wait till the end, or do you want me to wait here for any questions?
We will hold questions until the end.
Okay. Well, thanks again for letting me be here today, and I'll turn this over to Ashley Goss now. Thank you. Oh, my goodness. I apologize because this is late breaking news. I apologize. You may have seen just within about the last hour, KDHE made a rather large announcement related to contact tracing. For the last several weeks, there's been a lot of discussion about, first of all, with the surge in the cases you've all seen in the schools and elsewhere, the ability to continue contact tracing has become very difficult for the schools and for everyone, for that matter, because people are being diagnosed by the hundreds. And that would mean if they have 5 contacts, that's 500 people, et cetera, that you need to get a hold of. So we have worked with the school board, and we have issued a statement in a press release this morning indicating that we would like to have the schools, if they can continue contract tracing, to continue doing that, but if not, to discontinue that, to relieve one more stressor that they have already dealing with trying to keep kids in school and teachers and staff there as well. We will reevaluate that decision in 30 days, as we hope and are hoping that the latest surge diminishes. The second thing in the announcement that you will see is KDHE will discontinue contact tracing efforts related to COVID February 1st. And that will continue to be reevaluated. But again, the vast amount of cases is a driver. Additionally, when contact tracing started, the public was more willing to share information. We are not finding that the public is as willing to share information. And so efforts related to contact tracing end up being a little futile at this point. So you will see both of those things announced today. Okay. Thank you.
Thank you. Ashley, welcome to the committee.
Thank you. Good morning, Chairman and Committee. I'm Ashley Goss, Deputy Secretary for Public Health for the Kansas Department of Health and Environment. I think most of you have seen this slide deck before, but I'm happy to answer questions after we get through it. I'm going to start on slide 4, where it lists our divisions of public health. So in the Division of Public Health, we have 6 bureaus. Bureau of Community Health Systems, which oversees community health access, health facilities, so that's where you hear about hospital surveys, is under our health facilities program. Preparedness, radiation control, and then our trauma centers. I know many of you are familiar with our trauma program. That's where that one lies. We also have one of the more popular ones I'm sure you've been hearing about lately, Bureau of Epidemiology and Public Health Informatics. In that bureau, they house infectious disease epidemiology and response. Environmental health epidemiology section, they also look at trauma, injury, and drug epidemiology, maternal child health, chronic disease and behavioral risk surveillance, public health informatics, Office of Vital Statistics, which is birth certificates, death certificates, all the legal certificates that you need, vital health statistics, and disease condition surveillance. So EPI oversees many things, looking at the numbers, case rates of all kinds of things. Next, we have the Bureau of Health Promotion. In that bureau, we have several health promotion and or preventative programs, such as cancer, opioids, that's where our palliative care program lies, and our early detection works program lies, as well as our community clinical linkage program, our health promotion program, injury and violence and prevention program, chronic disease, and our community health worker section. Next, our Bureau of Disease Control and Prevention is where the rest of infectious disease section lies. So that one oversees and investigates STIs. That's also where our immunization section is, and also where our prevention and care section is. Bureau of Family Health houses our children and family section, early care and youth program section, nutrition and WIC services, screening surveillance section, and our birth defect section. And finally, the Bureau of Oral Health, a small but mighty bureau, houses oral health services for children, adults, and also community oral health education. Next slide. This is just a brief look at what happens every day in Kansas. I won't read it to you, but as you can see, we have 94 live births and 87 deaths every day in Kansas. Different reasons and causes are listed below. Next slide. Just an overarching slide about health beyond traditional health, and it's public health is not necessarily a specific agency or department. There's plenty of opportunities to be healthy, requires active processes, and to change the trajectory of public health and health in general, we must think differently. We need to challenge our long-held beliefs in order to improve. And as we know, health is beyond just health. It's all inclusive. Next slide. Last year, I believe we briefed you on the American Health Rankings. This is an updated view. They update them annually. Keep in mind the data lags 1 year behind. So There's several metrics that they look at. I'm only going to cover a couple of them. You guys can log on to the American Health Rankings site at any time and review the entire report as a whole. If there's something specific you're looking for, we're more than happy to help you with that. The state health rankings are a composite index of the state level population health measures. Each measure is ranked by the state's values, with 1 being the healthiest value and 50 being the least healthiest value. In previous years, we provided the Z-score of the data points, but this year we're going to make it simple and just provide state rankings, as I mentioned. Next slide. So overall, we rank 30th in the United States. We actually have fallen 1. We moved down from 29th. You can see that the state ranked 31st in behaviors, 24th in social and economic factors, 39th in physical environment, and 31st in clinical care, and 33rd in outcomes. I'll highlight some of the metrics in these domains, but as I said, there's 100 different metrics in this report, so it's on the website. Next slide. So behaviors, as stated, we rank 31st in behaviors. Included in this number is the nutritional and physical activity. So Kansas has ranked 27th for nutrition and physical activity, and some of the programs that we implemented to improve our rankings are as follows. In 2022, approximately $1.3 million was awarded to 23 grantees across the state, covering 34 counties to prevent initiation of commercial tobacco use among people, eliminate non-smokers' exposure to secondhand smoke, promote quitting among adults and young people, increase physical activity, access to healthy foods, community resilience, and improving the ability of those with chronic disease to manage their conditions. This would be everyday work in our Bureau of Health Promotion. 2021, Kansas was awarded approximately $185,000 to support the Kansas Senior Farmers Nutrition Program, which is much like the farmers market. However, it's directly targeted at Kansas seniors. And most recently, Kansas was awarded $144,000 through the state partnerships Improving Nutrition and Equity, otherwise known as the SPINE program. And what that program does is it addresses food and nutrition security through sustainable and equitable actions that tackle economic and social conditions limiting food and nutrition security. And finally, smoking. Kansas is ranked 33rd in smoking. Some figures around smoking that impact our state is as follows. We receive approximately $1.5 million to address tobacco use and prevention. The state of Kansas total annual tobacco prevention spending for FY22 is $1 million. CDC's recommended amount of spending for tobacco prevention is $27.9 million. Cigarette smoking in Kansas costs $1.1 billion in healthcare expenditures and another $1.1 billion in lost productivity each year. The healthcare expenditures cost covered by the state Medicaid program is $237.4 million per year. Kansas residents' state and federal tax burden is $904 per household to pay the annual health costs for smoking-related expenditures. On the next slide, we'll provide you some of the KDHE programs to help with tobacco prevention. So we have a RESIST program to target tobacco prevention. And our RESIST program is a youth-led statewide initiative movement created to fight against the tobacco's industry's influence in Kansas. RESIST is a collaboration between KDHE and Tobacco Free Kansas Coalition. RESIST advocates for the denormalization of tobacco use in Kansas youth and unites communities to create one voice to stand up against the tobacco industry. Youth not only participate in the tobacco control prevention activities structured by this program, but they also help implement and design the program using the Centers for Disease Control and Prevention. Next slide. Physical environment, we rank 39th. So air pollution, in 2021, all 105 counties have ambient air quality data showing compliance with all national ambient air control standards. In regard to drinking water and violations, the data themselves need quality control and cleanup. We've discussed past violations that have long since been resolved in the system. Kansas is vigorous in citing violations for significant deficiencies found during sanitary surveys, probably more so than other states. We do have serious nitrate and disinfection byproduct violations, reflecting the abundance of nutrients in our surface and groundwater supplies. One notable statistic to take from this is that 98% of the state population is served by public water supplies that is completely compliant with all health standards. And that number has been plus or minus 2% each year, according to our compliance reports. Next slide. Our physical environment, as you can see, this graph, there's been a drastic change from 1990 to 2019. We've seen an 81% reduction in point source pollutants into the air. So Kansas is doing well there. Next slide. Clinical care. I'm sure a lot of you have heard a lot about clinical care or the lack of access to clinical care. So Kansas ranks 32nd in the state for access to providers. We know there's a shortage of providers, essentially in the rural areas of the state. KDHE is responsible for administering the Kansas State Loan Repayment Program, also known as SLRP. This offers eligible healthcare providers an opportunity to receive assistance with the repayment of a qualifying educational loan in exchange for a minimum 2-year commitment to provide healthcare services of an eligible practice in the state of Kansas. SLRP is jointly funded by the state of Kansas and Health Resources and Services Administration, National Health Service Corps. Healthcare providers applying for SLRP must be employed by a nonprofit or public entity which has met the SLRP requirements. And the repayments range anywhere from $25,000 to $20,000. Next slide. Social and economical factors. So for social and economic factors, we rank 24. Overall, in regards to public health funding, Kansas is currently 39th. Kansas spends around $87 per Kansan for public health. The U.S. average is currently $116 per person for public health. And the state with the highest per capita spending on public health is Alaska, and they spend $449 per person for public health. There has been some movement on this in previous session. We've had several changes with local health departments, such as legislative session 2020. The legislature approved a $900,000 increase in our state formula starting in state fiscal year 21, signed by the governor but lost during allotment. Minimum increase went from $7,000 to $12,000 with no increase in funding to local health departments. Legislative session 2021, the legislature approved a $1 million increase in the state formula funding starting in state formula year 2022, signed by the governor, and we do have that in effect now. Legislature was also allocated a $1 million one-time allotment to be allocated via state formula. So the minimum increased from the $7,000 to $12,000. And in 2022, our current year, the governor's budget lists $4.2 million for state formula in state formula year 2022. This is under the assumption that we have a $2.2 million base with a $1 million increase from last session, and that $1 million one time that didn't get used yet. And with $3.2 million for 2023. The new value approved last session was 2.2 with a $1 million increase. So making progress. The Kansas Association of Local Health Departments does plan to seek an additional $1.6 million for the state formula in starting year of 2023. Another program, ACEs, which is known as Adverse Childhood Experiences, we currently rank 27. We do not have a dedicated program to this, but we have partners to collaborate. And we're just now in the process of getting a program off the ground, working with our partners, which is known as the Maternal Anti-Violence Innovation and Sharing Project. We have several partners across the state that we've involved in this work. And as I mentioned, it's in the early stages. We've had some partner meetings, but that will be the program that we utilize to help reduce the incidence of adverse childhood experiences. Next slide. Outcomes. For Kansas, we rank 33rd overall. Kansas is ranked 33rd in suicides. KDHE is dedicated in addressing suicide prevention through data collection, collaboration, communication, and programming, and integration. Many of our programs seek to increase awareness, encourage early identification through screenings, and promote referrals to the intervention and treatment. Beginning August of 2020, KDHE was awarded funding from SAMHSA in the implementation of the Zero Suicide Program in health systems in Kansas. This program is a framework to improve suicide care through increase in leadership and frontline commitment to a system-wide culture change to reducing suicide. This offers training for competent, confident, and a caring workforce, identification and assessment of individuals with suicide risk via a comprehensive screening and assessment, engagement of patients at risk for a suicide and care plan, treatment of suicidal thoughts and behaviors, providing continuous contact and support, especially after acute care, and improvement in policies and procedures through continuous quality improvement. Our Zero Suicide program, we do work with other state agencies that have suicide programs in place as well to try and make it the most collaborative program that we can. Kansas is ranked 29th in diabetes in the nation. And next slide. Each year, we publish a diabetes report for the state of Kansas. Next slide. For this last year, according to the diabetes report, diabetes costs Kansas about $2.4 billion a year. The state employee health plan spends about $46.9 million on diabetes. CanCare spends about $587 million on diabetes. And there was a median of 4 days in the hospital for Kansans that had diabetes. Next slide. In 2020, approximately 1 in 9, or 11% of Kansas adults, reported being diagnosed with diabetes. That's about 245,000 Kansans. 1.5 million Americans are diagnosed every year with diabetes. In the last 20 years, the number of adults diagnosed with diabetes has more than doubled. Based on the American Diabetes Association risk test, an additional 42.4% of Kansas aged 18 and over that currently don't have diabetes are at an increased risk of getting diabetes. Next slide. So the data is suggesting access to care is a barrier. So in order to improve that, we need to decrease the manpower shortages, always consider the geographic disparity in health outcomes, financial impediments, cost of care, looking at that and see what we can do. Transportation shortcomings, which that's something that is part of the social determinants of health that public health is constantly looking at in the communities on how we can increase transportation to care. Obstacles to care exist for mental health and substance abuse disorders, so finding a way to eliminate the obstacles. And of course, behavioral changes regarding nutrition, physical activity, drug and tobacco. Next slide. So what's next? We are constantly trying to learn about the health of Kansas, and by doing that, we do a state health assessment and a state health improvement plan every 5 years, 5 to 10 years. And we are currently in that year of doing that. And when we do these state health assessments and state health improvement plans, we reach out to partners, which I'll go over the list here shortly with you, and what that looks like. And then that's how our Healthy People 2030, how we derive that for Kansas. So currently we're working to engage Kansans in a new collaborative process and identify and address the current leading health challenges in our states. The resulting state health assessment, otherwise known as a SHAW, and State Health Improvement Plan, known as SHIP, is improved by the National Healthy People Framework and is known as Healthy Kansas 2030. Throughout the 18-month process, which we began in 2021, KDHE has worked with a contracted vendor, I. Boswell, to complete and issue an updated state health assessment and improvement plan. Again, this is ongoing. It has not been completed. Using partners, using NACHOs and the mobilizing for action through planning and partnerships, KDHE placed a strong emphasis on intentionally seeking and involving voices from whom KDHE had not previously heard from in previous years' SHAW and SHIPs. The new voices are emerging and energizing to this effort and holding KDHE accountable to the principles of health equity. These voices are part of the steering committee as well as the community themes, strengths assessment committee, community health status assessment, and forces of change. The Healthy Kansas 2030 State Health Assessment has included 23 interviews with 26 stakeholders from across the state. With the support of the steering committee, the Healthy Kansas 2030 Community Themes and Strengths Committee and KDHE leaders, staff, and consulting team identified and recruited interview participants that included nonprofit leaders, medical providers and health organizations, state and county legislators, representatives from the African American, Hispanic, Native American, LGBTQ, and veterans organizations, and partners with academics as well, thought leaders in public health. So those are the groups that we are offering, working with to complete the survey questions with and get their input and see what it looks like. These are participants from all across the state, so they're not just centered in Topeka or Kansas City or Sedgwick County. We need to consider our rural counties as well. The consulting team from I. Boswell has conducted focus groups within 10 of the target populations, engaging people from teens to seniors from all corners of the state. The steering committee will progress to the next stage of planning in the coming weeks to finalize the priorities for inclusion in the state health improvement plan. So we're getting closer to completion on that. Next slide. Opportunities for improvement, legislative initiatives. So as we talked about earlier, support and funding for existing programs, public health items in the governor's budget. I won't go over those again. We've already talked about them. And as far as with the expansion of funding and such. However, I do want to mention there is an initiative in the governor's budget this year that will expand our universal home visits through our maternal child health program. This was so in 2019, we had just over 6,000 maternal child health universal visits. And of those, about 3,800 of those were with pregnant women or postpartum, and nearly 7,000 children between the ages of 1 and 11. We provided home visiting services, and that allows us to help refer them to care or whatever it is they might need. 71% of the maternal child health universal clients had prenatal in their first trimester. 68% were breastfeeding at the time. 90% of those clients are non-smokers. The majority of these clients received education on safe sleep, immunizations, breastfeeding, infant care, and nutrition. Of those, our maternal child health clients received 5,218 referrals to other services. Of those referrals, 52% were complete. The majority of the referrals were for postpartum care, education, breastfeeding, and early childhood services, and parenting and pregnancy education support. Something else that will support maternal child health program that is also in the governor's budget, and these are Medicaid items. So the governor's included $1 million in state general fund for formula year 2022 and $4.2 million in 2023 to expand Medicaid coverage for postpartum women for 10 additional months. Right now it currently ends at 60 days postpartum. And given some of the research that we've been doing with our maternal mortality review committee, we have seen that had women had extended coverage, we would have been able to get them referred to services, and some of the conditions and experiences that they had without coverage could have been prevented or at least cared for early on. Currently, about 2/3 of women of the pregnant women eligibility group loses Medicaid coverage about 60 days postpartum. Our maternal mortality review found that nearly half of the pregnancy-associated deaths occurred after 42 days postpartum. Medicaid moms we have seen are the most at risk, and the state plan amendment would allow both mom and baby to be covered for the first year of the baby's life. KDHE has asked the KFMC to study the actual experience of moms whose eligibility has been extended during the pandemic. Most states are actively working to extend coverage for postpartum women, and some have already got it extended. And that's all I have. We will stand for questions.
Ashley, thank you. And committee, we will open up for questions for Ashley, and then we'll go, since she is up at the podium, and then we'll go to Acting Secretary Standing. Senator Gossage.
Thank you for being here. I have a couple of questions for you. Do you know how many births were paid for by the taxpayers through Medicaid?
I don't have that statistic, but we can certainly get it for you.
Thank you. And in your statistic, it shows there were 9 COVID deaths daily. According to the data that comes from healthdata.gov, thankfully, those deaths are down. So can you tell me what this death rate is based upon?
Yep, if you will allow me to call our state epidemiologist up for Ahmed, she can explain what's in the data.
Great, thank you. And then we talked about smoking, and I was trying to write furiously as you were giving us the information about $1.3 million here and $1.5 million there and recommended, et cetera. But it looks like we haven't really changed as to our status.
Right.
So, if you look at return on investment, is that really reducing the number of people that are smoking?
It isn't, but I also pointed out in that slide as well that we are way underspending for the state of Kansas in smoking prevention. So we can only do what we can do with the funding we're allowed for programs. And so it's kind of a never-ending battle.
I guess I'm trying to understand, with all the data and information that's out there now, discouraging people from using tobacco, what did you say the recommended was?
The recommended is from CDC, and it's right around $24 million.
$24 million.
That would allow for more hands-on programs to be implemented. If you want to know what other states are doing, Senator, I can get that information for you as well from our staff that run these programs.
Thank you.
Yep, absolutely.
And let's see, I think my last question was regarding the, what you were talking about with the maternity. And so, yes, if you could just get that information to me about
Sure.
how many women we're talking about. Thank you very much.
Yep. And would you like Farah to come up and explain the statistic?
For,
COVID deaths?
yes,
Right.
if that's okay with the chair.
Yes, go ahead.
Good morning. My name is Farah Ahmed. I'm the state epidemiologist at KDHE. So the way that we calculate the death statistics, the certifier, so the physician or the medical examiner who oversees the death signs off on the death certificate. And if they list COVID as the underlying cause of death or a contributing cause of death, then it will get tallied in our tallies as a COVID-related death. And so when we report on the daily average number of deaths, what we're actually looking at is the date of death. So if you're familiar with death certificates, you know that the certifier can actually take up to 6 months to get us that final certificate. So instead of looking at when that certificate came in, we look at when that person died. And so when we look at when that person died, for about the last 3 to 4 weeks, we have fluctuated between about 6 to 9 deaths per day.
For the last how many weeks?
I would say about the last 4 weeks or so. It's gone from 6 to 8 to 9 to back down to 8.
Okay, so, but you're saying that this could have come in a couple of months ago. It's not recent. It's not in January, deaths in January.
It is, these are based on the date of death. So we are averaging between 6 to 9 COVID-related deaths per day.
And they test everyone that comes in the hospital for COVID. So if someone were to die of something else but happen to have COVID, it would be considered COVID-related.
That would be up to the person that is certifying the death certificate. In some cases, if they feel like COVID was a contributing factor, so say that person had heart disease, but COVID pushed along the heart disease, they might list it as an underlying or contributing cause of death. But if the physician doesn't feel so, then they won't.
Thank you.
If you don't mind staying up for that perk day question for me. You said it averages between 6 and 9, but you use 9 in your graph. I'm just curious why you used the higher number.
I would need to know when that data was pulled. So over the past month, because we update it 3 times a week. So I would say that over the past month, updating the data 3 times a week, it's fluctuated between 6 to 9. So it would depend on when that data was pulled.
Okay, so you just used the highest number. Senator Thompson.
Might as well stay up there. A little confusing. So you say you're using the date of death. So are you going and adjusting data that was previous based, in other words, okay, say you find out that it was, COVID was listed on there and you say that was a COVID death, you go back to that date and adjust the graph at that time, not today's date.
Correct. We go back and adjust it to that time.
But with autopsy, we know most of these people don't have autopsies, correct? And I know for a fact that at least 30% of the deaths listed without an autopsy are probably incorrect. Is that that's the data that was given to me by the previous director of the KDHE. Is that correct?
Not that I know of, but I can certainly figure out where that
Yeah.
statistic came from. I don't know if the previous secretary was talking about a specific disease. So there are absolutely going to be specific diseases that probably get misclassified more often than others.
And you would say probably COVID would fall into that?
No, I don't have any evidence to say that COVID would be one of those diseases, no.
Okay. What type of tests are being used to determine right now whether somebody is COVID positive or not?
There's a few different types of diagnostic tests. So you might hear of an antigen test and you might hear of a PCR test.
Okay.
So an antigen test is going to look for the protein specific to the virus, and a PCR test is going to look for the genetic material specific to the virus. And those are the two types that would be used for diagnostic purposes.
And the rapid tests, are those PCR tests?
You can have rapid antigens and you can have rapid PCRs. So the rapid just implies that it's a point of care test, meaning you go to your physician or whoever, you're getting it done, you probably get results right there between 15 to 30 minutes. And that's what indicates it's a point of care rapid test, as opposed to if your sample goes off to a lab to be analyzed.
How accurate are the PCR tests?
PCR is very accurate. What it's looking for is, again, the genetic material. And it comes down to a little bit of interpretation. So if someone had very recent infection, so you've just had infection naturally within the last 90 days or so, if you get another PCR done, you might still be PCR positive. So that's why we kind of look at the whole scenario, because you could shed virus for a while, even if you're not infectious to other people. So if someone had recent disease, we really encourage their provider to test them with an antigen.
One more, I'm sorry, Mr. Chair. I've heard people testing positive after they've gotten the vaccine, is that correct?
You can get a breakthrough infection. So if you have a fully vaccinated person who is then exposed and then develops disease, then that is called a breakthrough infection. And yes, that is possible. The vaccine itself is not what is causing you to be positive. There's nothing in the vaccine that would give you a positive on an antigen or a positive on a PCR. It would show up on an antibody test, right? That's where that antibody test is going to tell you that your body has built up antibodies, which is what it's going to do if you are exposed naturally and what it's going to do if you get a vaccine.
That would, but the antibody could be quite some time afterward.
It's generally a couple of weeks. Most people develop antibodies in 2 to 3 weeks after.
Thank you, Mr. Chair. I'll stand aside and let some other people ask questions. I've got plenty more, but here, I'll let you.
You know, you made a comment that it's left up to interpretation. We don't like those. So if you can refine that to where it's not interpreted, but it is exact, we'd appreciate it. Senator Stephan.
Thank you, Chairman. And that brings up the point when you're talking about COVID deaths, it sounded like you testified that there is no standardized approach to decide if a person actually died of COVID or not. Is that correct? You said it's left up to the physician signing the death certificate, correct?
There are standards and guidelines for those physicians, but it essentially boils down to their professional opinion. So if they truly don't feel like COVID contributed to that death, they will not list it on the death certificate.
You're not out educating physicians on how to make a decision as to whether to put COVID on there or not as the source of death.
They're provided the education that comes from the National Center for Health Statistics, but we do not tell them how to fill out a death certificate, and we do not amend death certificates.
Yeah. On the COVID test, not long ago, CDC came out with an advisory to healthcare facilities and testing facilities in regards to the 2019 PCR test. It said, quit using it, you need to move away from it, and then indicated that it really was not able to differentiate between the COVID and a whole lot of other viruses, which explained why we had no flu last year. How reliant is the state of Kansas and the different testing sites on the old 2019 PCR test?
So that's not exactly what CDC said. What they did was they did not renew their emergency use authorization for that particular test because a new multiplex test has been used now. So now we test for COVID and flu on the same test, whereas in 2019, they were just using a test that just looked for COVID. So now that we have a test that looks for both, they didn't feel the need to renew the authorization for that COVID-only test. That's what it was.
Senator O'Shea.
Thank you, Mr. Chair. I believe my question's for Ashley. Oh, thank you. So as I take this presentation, and I'm struck thinking about how much of this is so personal and begins in the family units and at schools and things like that. So I was curious how your department works with children and families and education to infuse this and make it a collaboration.
We work with them quite frequently, actually, and our family health bureau that I mentioned, that bureau is 0 to death, essentially is the population they serve. And that's where our maternal child health program lies. They are intertwined with KSDE as well as DCF on a regular basis. They're two of our partners that we work with on a continual basis when we're developing programs and figuring out what would be best for kids and families as a whole. We also work with KDADS too, because they have the behavioral health side of things. We have programs as well, but KDADS has more. And so we work with them as well. We don't do the work in a silo. We know it's super important that we have to include our sister agencies and other partners that are outside state agencies as well to make robust programs. Mm-hmm.
Senator Petty.
Thank you, Mr. Chairman. Ashley, this is for you. In the health rankings, how many of the top 29 states, since we're ranked 30th, have passed Medicaid expansion?
That I will have to get back with you on. I don't know off the top of my head. I'm quite certain. Liz says she doesn't know off the top of her head, so we can find that out for you.
Since there's 34 states that have passed Medicaid expansion, it seems like the majority. I was looking back at page 9, and this goes back somewhat to the questioning that Senator Gossett should ask, because you did provide a lot of information. I know you mentioned when asked the question about that we aren't seeing a big change in the number of people that are smoking in Kansas, although it does look like there is a decrease in smoking younger.
Right.
Which is good, because you start younger, then you're going to be smoking a lot longer in your life, and that leads to all the health issues. But you did, so CDC has a recommendation of states spending $24 million on smoking cessation, and we're spending $1 million. Is that correct?
Right.
Okay, there is a big gap there. And you did give us a fact of how much per household it's costing every household because of smoking. What was that number?
That number is $904. And that was taken from a specific data source, which if you need more information on that, we can provide that too for you.
So what exactly does that mean?
The impacts of smoking as a whole, and again, I'm going to speak high level because I don't have the data source in front of me. It's rather lengthy of smoking, what it costs, the health impacts, all the things as a whole, looking at it is what comes into that number. And so if you need specific data elements, we can for sure get you that so that you know what exactly is included in that household number.
Okay, I think that's very important, because we often forget how pervasive smoking is and how invasive it is to health long-term.
Right.
And so when you hear these kinds of numbers, Maybe I am not a smoker, I've never been a smoker, but I came from a household that was, my parents were smokers, and their life issues later in life were impacted by their smoking. So that's very helpful. Then on page 14, sorry, I'm going to get back to it. This is concerning the social and economic factors. You were talking about money going for public health funding, and so I wanted to be clear, there's an additional 1 million that's going in this year.
I believe so. I think, yes, I believe so. It had gone in and then it didn't make it through the final stages. COVID happened.
Right,
And
that was
funds had
the
to
year
be
prior.
diverted.
So
Right.
last year, and we also raised the base.
Right.
The minimum base for a health department. But then you mentioned, so there's a proposal asking for 1.6 million more starting in 2023?
Right.
So is that in the governor's budget or that's being proposed?
So currently, for 2022, the governor's budget lists 4.2 million in state formula, but that's under the assumption of the $2.2 million base, and then the $1 million increase from last session, and then the $1 million one-time that didn't get used. It got put in, but then didn't get signed. That was 2 years ago when session ended early, went remote. And then take that million away for next year for 2023, and it puts it back at 3.2.
Okay, so it would just be a one-time $1 million.
Yes.
So what am I getting that 1.6 million?
CALD is going to ask for 1.6 million this year, in addition to what the governor already has in her budget. So the Kansas Association of Local Health Departments will be asking for an additional 1.6 million.
Okay, so that would be bringing it up, if that was an addition made, that would be bringing it up to 4.6 million, would that be correct?
4.6, yes,
Yeah.
next year.
2023. Yes. Okay. And then under the, and this kind of goes along with Senator O'Shea was asking about, you were talking about ACEs. I mean, we've had a lot, I mean, DCF has been working tirelessly with the adverse childhood experiences. So are you, so this is something that KDHE has been involved in, and I'm trying to, so is there really, we're talking about working to expand the programs that we have?
Right, because we don't get specific funding to address ACEs, so we have to work with our partners and perhaps those that have funding that can help us address it. So we're just getting established what's called MAVIS, M-A-V-I-S, but all the words are Maternal Anti-Violence Innovation and Sharing Project. And so the partners that we work with for that so far are the Kansas Coalition Against Sexual and Domestic Violence, Kansas Connecting Communities, KPQC, and the KMMRC. And we're working to launch that program. And the goal of the program is, of course, to reduce maternal deaths in Kansas due to homicide and suicide. And then the MAVIS project will continue to build and expand on the successes of the maternal mortalities to gather additional data related to violent maternal deaths. We'll also provide cross-training to perinatal care providers and domestic violence service providers related to the perinatal mood, anxiety disorders, perinatal substance use, and intimate partner violence. But this is just really getting going. The first few stakeholder meetings have been held, but we're not at all ready. It's not in launch phase yet. It's getting everyone around the table, coming up with what it's going to look like to launch.
Committee, we're running out of time, and I want to make sure we have questions for Acting Secretary. Ashley, if you don't mind, please don't do a study on the effect of Big Macs along with the smoking.
Okay, no, I won't.
So if we do have a couple of quick questions, I mean, very, very quick, and if the responses can be very, very quick, that way we can move on to Acting Secretary Stanek. Senator Gossage.
Thank you, and mine are very quick, Mr. Chair. Thank you so much again for being here. I'm curious if the CDC is recommending 24 million be spent on deterring people from using tobacco. it seems more like to me that that should be based on population. When you've got 737,000 people in Alaska and 20 million in New York, 3 million in Kansas, it seems like that should be a percentage of, based upon population.
Right, and it was just, I think as a whole, what should be being spent. We can look to see if they have specific guidance for Kansas on what we should be spending. It's kind of arbitrary because it is what it is. They aren't giving us any more money for it to implement
I'm
programs.
curious how that money is used, et cetera. Thank you so much on that.
Certainly.
And then finally, to the epidemiologist, two quick questions.
No, Senator, we're going to have to cut it because we need to get.
Okay, I'll ask you after
Okay.
if that's okay.
Thank you. Senator Holscher's online.
Great. Thank you, Mr. Chair. I do have a couple of real quick questions. In regard to vaping by high schoolers, do you know where we are compared to the past couple of years, if that figure has gone up or down?
I don't have that statistic off the top of my head, Senator. I can look into that for you and get you that answer if you would like.
That would be great. And then the other question, in regard to the SLOPE program, do you know how many people we have taking advantage of that currently?
Oh, wow. You're asking me data point questions. I don't. The number has gone up because funding has increased. I can get you that as well.
Okay, that'd be great. Thank you so much.
You're welcome.
Committee, do we have questions for Acting Secretary Stanek? Senator Gossage.
Thank you. And thank you also for being here. Do you know, or anybody on your staff that could get back to us about good places to get an antibody test? We just keep hearing of they're not accurate.
I'm going to defer to Farah on that question.
I'll just answer very quickly. The reason that you keep hearing that they're not accurate is there are no commercially available antibody tests that can tell you that you have built antibodies specific to the SARS-CoV-2 virus. So most commercially available antibody tests are just going to tell you that you've built antibodies to coronaviruses. Coronaviruses is a big family, causes the common cold, et cetera. So that's why we discourage people from just running out, getting an antibody test and assuming that they are immune to getting COVID-19. The other reason is that the research is not there yet to say if you have this level of antibodies specific to the SARS-CoV-2 virus, you are therefore considered immune. So there's not enough research to say what level of antibodies you would need circulating to confer immunity and for how long. That's gets all wrapped up in that antibody tests are not accurate kind of statement.
So you said commercial, but there's none? Like you can't, your doctor couldn't order one through Lab One or something to see?
There are certain labs in the US that are able to test for specific antibodies. And if you'd like, CDC actually has a national network of labs where they have been putting out data on what is essentially the SARS-CoV-2 level of background antibodies in a population. And we do have Kansas data for that.
Great, thank you so much.
Yes, absolutely.
Senator Thompson.
Thank you for Acting Secretary Stanek. Thank you for being here. I've seen billboards, television ads, mailers on the campaign to get people vaccinated. How much money has been spent on that and how much is dedicated going forward for that effort?
I don't have the specific number on me, but I can get that. There is more money being spent on advertising and marketing, but I'll have to get back to you on that.
Yeah,
figure.
I'd like to get a number on that.
Yes, sir.
And why has there been no disclaimer on those ads? I mean, your part of your job is educating people about vaccinations. There's been no disclaimer about the dangers of vaccinations, and there's data to support that there are adverse reactions with these particular vaccines.
I think, I can't speak to the billboards because I can't picture one offhand, but I would just say from a consent perspective, people consent to things, and there are always adverse effect indicators on there that people read and are explained before they consent to a treatment. That's like any medical procedure, and I believe it's being done more at the point of care.
But there's no effort by your agency to at least put a seed of doubt in people's mind. From everything I've seen billboards, TV ads saying, get the shot. Simple as that. No, hey, talk to your physician and consider whether or not there might be some dangers involved.
I can't speak to that specifically. I'm not sure if I could turn to my colleagues and ask if there are any other notifications that we're aware of.
Some of them do say, speak to your physician on the ads, and then, of course, they're also given the list that any other childhood immunization or adult immunization has. They are given ahead of time with what the risks and what.
Ashley, I apologize, but could you come up to the mic and state your name and restate that, please?
I'm afraid you're going to tell me not to research anything else. I only committed to Big Macs. So when some of the ads have said, speak with your physician before getting the vaccine, or if you have questions, go talk to your primary care provider about it. So if you're not sure, go talk to them, find out what the risks are, find out if you should get it, find out if you shouldn't get it. But then also, like any other vaccine, there is also an information sheet that comes with them. Those are handed out ahead of time, or at least we hand them out ahead of time. I cannot speak for providers. I can only speak for what we do. There's an information sheet that is handed out ahead of time that very clearly states on it what your risk factors are, what the side effects have been that have been seen, if any, and this percentage so far that's seen with that vaccine. But that's how it is on all of our vaccine information sheets. Does that help answer your question?
Not really, because what I'm getting at here is that the perception is the vaccines are safe and effective. And I've seen nothing in the ads that would for me to be, I've done a lot of research in this, and some people have, but most people don't. And most people believe these things are safe and effective. We know people are getting COVID. We know people are actually dying from these shots. There's nothing that indicates to me in these ads that you're doing your diligence to say, wait a minute, this vaccine does carry risk. You are encouraging people to get a vaccine and not educating them on the information. I think there should be a disclaimer on any additional advertising going forward. That would be my recommendation.
Again, we try and work with the primary care providers and provide them the information. And there's many people that go to their primary care providers to get the vaccine. And we want the conversations to be had with their PCP where their home is.
Thank you, Mr. Chair.
And before we go to the last question, I just want to clarify. You guys said a couple of things, which is contrary to past, so I want to make sure I heard it correctly. That you believe that it is up to the individual and their doctor to decide what is safe and best for them, and that they should have to give consent. So is that the official position of KDHE now, that mandates should not happen?
We don't have a mandate for COVID vaccine, nor are we seeking one.
No, but I just want to clarify, you do not support a vaccine mandate.
The governor doesn't support the vaccine mandate as well. We don't support a vaccine mandate. We always want people to go back to their primary care physician. That's where their home is for medical care. And so if there's ever any question, please go back to the person that knows you the best. We don't support a mandate, no.
Okay, thank you. I wanted to clarify that because this is election year and things will change afterwards. Senator Stephan.
Yeah, I would like to comment on some of this last statement. This idea that it's okay for a government agency to claim that this vaccine is safe and effective, and then turn around and say, "Oh no, we push that off onto the physicians." Well, most of these aren't even being done in the doctor's office. That's duplicitous. To say that it's okay for you all to say in public and to people that it's safe and effective. I find that morally objectionable. I find that legally objectionable. Where are you all at with early treatment? Those of us who study this virus and understand this virus understand how important and how nuanced early treatment is, and yet we don't hear anything from you guys about ivermectin, hydroxychloroquine. All we hear is just the CDC mantra being blown through the speakers. What can you do to help people not suffer and die from an early treatment standpoint?
I don't know if I can answer that question to the degree that you would like. I would say that the safe and effectiveness comment We have to rely on science and what's being shown, and the CDC is that source. We do follow the science and safety guidelines. That is our job. And I appreciate your comment related to the safety and the individual going back to their primary care physician. Like any procedure, pill, anything, people with different comorbid conditions are going to react different or may react different. That is why, for those people, it's probably more important that they consult with their physician. But overall, the data has proven that the vaccine, for the most part, is safe and effective, and I can't speak to early treatment today.
The default statement is the data shows. Show me the data. Bring me the data showing that it's safe and effective. I want to see the studies, please.
Oh, okay. We will look into trying to get you something concise.
Okay. Acting Secretary, thank you very much. Committee, we are out of time.
Thanks.
Jenna and Connor, I know you guys were really looking forward to giving us that bill brief update, but we are out of time, so we'll have to save it for another day.